Hello, my name is Dr. Victor Rodriguez. I'm a medical oncologist at Sunnybrook Odette Cancer Center. I do specialize in neuroendocrine tumors and their management. And I would like to thank the CNET's Foundation for this kind invitation. I will be talking today about general management of high-grade neuroendocrine neoplasm. But let's start from the beginning. You might have heard about the high-grade neuroendocrine neoplasm, but there may be some confusion about some of the terms that we usually use in clinic, and we might refer to neuroendocrine neoplasm or neuroendocrine tumors or neuroendocrine carcinomas, and there may be a bit of a misunderstanding. So neuroendocrine neoplasm is a pretty novel term that we are using much commonly right now. We can also refer to neuroendocrine tumors, but also we can refer to neuroendocrine carcinomas. And let's talk about this. So neoplasm tumor, they usually refer to the same terms, and essentially means that the normal mass tissue that results when cells divide more than they should or do not die when they should. When we talk about carcinomas, we refer to a more aggressive form of tumor that can really metastasize. So what are the high-grade neuroendocrine neoplasms? They are a rare subgroup, but they're aggressive. They're newly defined by the WHO classification since 2017, when the WHO divided the neuroendocrine tumors in high-grade neuroendocrine tumors grade 3 and neuroendocrine carcinoma. And this was based on essentially morphology, which is essentially how the tumor resembles to normal cells, but also in the using what we call the Ki-67 index that we will talk about later. So as we see, we can differentiate between well-differentiated tumors and poorly differentiated tumors. Well-differentiated can be divided into 3 categories: grade 1, grade 2, and grade 3, that they're the grade 3 being considered the high-grade tumors. And they usually have a Ki-67 index greater than 20%. Whereas the poorly differentiated, we define them on the basis of the morphology, regardless of the Ki-67. As I said, the Ki-67 is the most important prognostic factor in neuroendocrine tumors, and essentially refers to the cells that are at the given time, they are actively dividing. So it gives us information in terms of prognosis, but also in terms of how aggressive is that tumor. But not all high-grade tumors are the same. As I said before, differentiation is a key for predicting tumor behavior. And within the well-differentiated grade 3 entity, there might be tumors that they behave more an indolent way, more grade 2 tumors, whereas the poorly differentiated tumors, they usually behave more aggressively. They have significant difference in survival, and usually poorly differentiated neuroendocrine carcinomas have poor outcomes compared to well-differentiated but grade 3 neuroendocrine tumors. But don't forget that we should know that there are other factors such as tumor stage, age, comorbidities, access to care that also plays a significant role in the survival of our patients. And the other factor that I would like to point out today is that when we speak about survival, usually numbers typically come from analysis of limited group of patients and does not apply to individuals. We also should know that might be difference in terms of treatment response. We do know that the well-differentiated grade 3 neuroendocrine tumors usually responds better to different type of chemotherapy compared to the poorly differentiated ones. And again, within a given tumor, within a given patient, there we should be aware of what we call tumor heterogeneity, which means that there may be areas of tumor that are behaving less aggressively than other areas. And this is really crucial and important for us. We are currently undergoing a clinical trial at Sunnybrook along with Princess Margaret, where we are combining two different imaging methods, the gallium-68 PET scan and also the FDG PET scan. Essentially will give us information in terms of the biology of the tumor. We want to know if there are some areas within a patient that reflect to a more aggressive form of tumors. And that can give us an information that is really important for us to really tailor the treatment. And I give you some sample. If within a patient we see a really avid FDG tumor, we should probably offer some sort of chemotherapy. So if the tumor behaves more aggressively, we should act in a more aggressive way. So essentially, what are the options in the management that we do for high-grade neuroendocrine neoplasms? We should be talking about what are the management for patients that undergo surgery. There may be other patients that are not undergoing surgery, and there are patients that unfortunately present with metastatic disease, that surgery is contraindicated, and then we usually offer them chemotherapy. So for patients that have localized disease and patients that can potentially undergo surgery, there's still a debate in the scientific committee, in the scientific population whether we should undergo or offer surgery for high-grade tumors. We consider that for localized, well-differentiated grade 3 neuroendocrine tumors, we should be offering resection, but further studies are required to fully understand the impact of surgery and on the survival of our patients. Whereas for poorly differentiated neuroendocrine carcinoma, we consider that given the chances of recurrence, they should not undergo typically a resection. After the resection, we offer them a combination of chemotherapy, usually is a combination of platinum and etoposide, and we should discuss whether radiation is an option or not. Again, we have limited retrospective supportive data to determine the impact of this approach. There may be cases that they're contraindicated with given the advanced disease, and there's some debate about whether some sort of neoadjuvant therapy or chemotherapy can downstage the tumor and making surgery feasible, but this is still debatable. We do know that, unfortunately, for those patients that with neuroendocrine carcinomas, with poorly differentiated carcinomas, usually are difficult to treat, and that the available therapies are very unsatisfactory in terms of efficacy. But we do have novel treatment options that we will be talking about. Just the European Oncology Association just published a treatment guidelines for including high-grade neuroendocrine tumors. And as you can see, for patients with neuroendocrine tumors, particularly pancreatic tumors, we should offer them a combination of chemotherapy, either a combination of capecitabine and temozolomide, and whereas for patients with poorly differentiated neuroendocrine carcinoma, as you can see on the right side, the combination of chemotherapy usually is based on platinum and etoposide. When they progress, if they progress, then the different treatment options for poorly differentiated carcinomas we still offer them chemotherapy combinations such as FOLFIRI or FOLFOX or CAPTEM, whereas for well-differentiated neuroendocrine tumors, upon progression to first-line chemotherapy, we can explore different treatment options such as PRRT, or a targeted agent such as everolimus or sunitinib. As I said, there are new ways to treat high-grade neuroendocrine neoplasms. For those rapidly growing tumors, we are evaluating and understanding the efficacy of new chemotherapy combinations. As I said, capecitabine and temozolomide, particularly for those with pancreatic neuroendocrine neoplasms and a Ki-67 less than 55%. There just been reported a phase 2 clinical trial of a combination of cisplatin and irinotecan, and another drugs combination that can be explored, a combination that usually we offer for other gastrointestinal type of tumors, such as FOLFOX, Celox, or FOLFIRI. There are ongoing clinical trials for neuroendocrine carcinomas evaluating, as I said, different chemotherapy options such as FOLFIRINOX or nab-paclitaxel in combination with carboplatin. So essentially, the field of exploring novel chemotherapy options is growing. We can also offer, or at least explore, whether a new treatment, which is called PRRT, can be offered. And essentially, this treatment is based on a lock and key principle. The targeting molecule, which essentially is a peptide, is similar to the somatostatin, which is a natural component, binds to the tumor-specific receptors, in this case, somatostatin receptors, and it's combined with a small amount of radiotherapy. So it's an IV treatment. So essentially, the molecule binds to tumor-specific receptors, and with the addition of radiotherapy, it kills the tumor cells. The challenge here in high-grade tumors is that there's a decreased expression of the somatostatin receptors within the high-grade tumors. And that's why it is important to understand the tumor biology and potentially offer and pursue the investigations that I talked before regarding the gallium-68 scan and the FDG PET scan to understand whether the tumor really expresses these receptors. We are running a clinical trial, actually here at Sunnybrook Hospital, that high-grade neuroendocrine tumor patients are being offered PRRT or high dose of standard somatostatin analogs. You might have heard about immunotherapy. There's a potential for immunotherapy in particularly high-grade neuroendocrine tumors. As you can see here, there's although for single agent immunotherapy, we haven't seen significant results, but there is a potential for immunotherapy combinations that we are exploring actually. We should be aware that there's a new marker, it's a MSI, is about positivity is around 5% in neuroendocrine carcinomas, and is essentially means that this is agnostic benefit for immunotherapy in these cases. So it's something that we can potentially explore and organize these tests. As I said, different clinical trials are now exploring different immunotherapy combinations. This is a clinical trial that's been running in Spain, and it's a combination of cabozantinib and atezolizumab for neuroendocrine neoplasms. And the beauty of this trial is that, as you can see at the bottom, the cohort 6 also allows inclusion of high-grade neuroendocrine neoplasm. But the key, in order to improve the outcomes of our high-grade neuroendocrine patients, is the multidisciplinary approach. We need to get every expert involved, including medical oncology, surgical oncology, radiation oncology, but also providing support, nursing support, palliative care, as well as dietitian, among others. And thank you very much for the invitation.